Good morning. Before we go in for today's topics, last class, some of you have asked me a few doubts. Is butterfly sign on MRI a diagnostic of a medulloblastoma? Basically, a butterfly sign per se, it is seen in normal infants. It depicts the choroid plexus on a fetal ultrasound. It is not seen in a medulloblastoma. There is, however, a butterfly glioma that is seen in grade 4 astrocytoma, not in medulloblastoma. One more question was, does choroid plexus papilloma cause changes in the composition of CSF? The main difference that happens is in choroid plexus papilloma, the metastatic cells are seen in the CSF sometimes. And one more was, is burr-hole craniotomy recommended for meningioma? Craniotomy is recommended for meningioma. I could not find anywhere literature that supports the use of a burr-hole for meningioma. Burr-hole is usually used as an approach for craniotomy. That is done for a meningioma. And one more last question was, difference between Rathke cyst and craniopharyngioma. As I have already told you, Rathke cyst has no BRAF mutations, whereas craniopharyngioma, the main feature is the BRAF mutation. And okay, going into today's topic, scalp. I have already told you the layers of scalp. What is a scalp? It is the soft tissue that covers the vault of the skull. It extends from the superior orbital margin to the superior nuchal line in the back. On each side to the superior temporal line. It is the hair-bearing area of the skull. What are the layers? The mnemonic is again scalp. S is skin. C is the connective tissue. A is the aponeurosis. L is the loose areolar tissue. And P is the pericranium. Now below this is the layers of your meninges. That is the dura 2 layers, the pia and the arachnoid matrix there. Now what is the skin? It is the thick and hairy. It is firmly attached to the epicranial aponeurosis through a dense fascia. There is abundance of sebaceous glands, so the incidence of sebaceous cysts over the scalp is quite high. What are the connective tissue? This is fibrous and dense. It contains the blood vessels and the nerves. It binds to the subjacent aponeurosis. Now, because it contains blood vessels and nerves, there is profuse bleeding when it is damaged. The profuse bleeding is actually prevented from retraction by the fibrous tissue. Bleeding is stopped by simply applying pressure against the bone. Now, subcutaneous hemorrhages are not extensive since the fascia is dense. Inflammation causes little swelling but of more pain. Now, this is the second layer. Next, what is aponeurosis? It is anteriorly the frontal belly and posteriorly the occipital belly of a muscle called occipitofrontalis. So, in the back it is occipital belly. In the front, it is the frontal belly. It is called occipitofrontalis muscle. The frontal belly originates from the skin of the forehead. It is continuous with the skin of the forehead. Whereas the occipital belly, it originates from the lateral 2/3 of the superior nuchal line. It gaps if cut transversely and it requires suturing. Now this is, you can see on the front, it is the frontal belly, and in the behind it is the occipital belly. What is the loose areolar tissue? It extends anteriorly into the eyelids, because the frontalis has no bony attachment. Now posteriorly, once again to the superior nuchal line, on each side to the superior temporal line. Bleeding is causes generalized swelling of the scalp. Now this is also called the dangerous area of scalp. Why? Because the emissary veins, they open into this loose areolar tissue region, and any infection here because of the trauma is carried inside to the brain via the venous sinuses. This is called the dangerous area of the scalp. Emissary veins in the loose areolar tissue carry any infections to the brain. Now, bleeding can also lead to black eye because it extends anteriorly up to the eyelids. Now, caput succedaneum is seen in newborns. It is not a pathological condition. It is a transient condition that is happening during birth, and it subsides on its own after a few days to weeks. What is the pericranium? It is the periosteum of the skull. It attaches loosely to the surface of bone but is adherent to the sutures, that are the sutural lines of the skull. Now, injury deep to it takes the shape of the bone. Scalping injury should be replaced and stitched because healing is better when we intervene. Now, what is the blood supply of the scalp? You have arteries that are the supratrochlear, supraorbital, and superficial temporal in the front, and posterior auricular and occipital artery in the back. Now the veins follow the arteries. Now here the 3 in front of the auricle and 2 behind the auricle. The ones in front of the auricle are supratrochlear, supraorbital, and superficial temporal. The ones behind the auricle are posterior auricular and occipital. Now, what is the nerve supply? Once again, it is divided into in front of the auricle and behind the auricle. The ones in front of the auricle are supratrochlear nerve, supraorbital nerve, zygomaticotemporal nerve, auriculotemporal nerve, and the temporal branch of facial nerve. It generally corresponds to the anatomy of that region. Like you have the trochlear region, orbital region, zygomatic region, and temporal region. So the nerves are named after them, like supratrochlear, supraorbital, zygomaticotemporal, auriculotemporal, and temporal branch of facial. Now, behind the auricle, you have the greater auricular and the lesser occipital, and the greater occipital and the third occipital. Three occipitals that are greater, lesser, and the third occipital, and a posterior auricular branch of facial nerve. Now, among these, 5 in front and 5 behind the auricle, 4 are sensory and 1 is motor. In front of the auricle, what is the motor branch? That is the temporal branch of facial nerve. Now, behind the auricle, what is the motor branch? That is the posterior auricular branch of facial nerve again. The rest 4 of them on front and behind form the sensory nerves. These originate in front from the trigeminal and behind from the cervical nerves. Now, what are the lymphatics? Anterior part, it drains into the preauricular group of lymph nodes, that is the parotid, and the posterior, they drain into the mastoid group of lymph nodes and occipital group of lymph nodes. Now, that's it about scalp. You will only be asked questions regarding the blood supply and basic layers of scalp. It's just 2 mark or maybe sometimes a 4 mark question for you. Now, next topic, the peripheral nerve injuries. Now, first of all, what is a peripheral nerve? These are bundles of axons that conduct efferent impulses from the cells in the anterior horn of the spinal cord to the muscles. That is, they take information from the spinal cord to the muscles. These are called efferent impulses. And the peripheral nerves also take afferent impulses from the peripheral receptors via the cells in the posterior root ganglia to the cord. Now, all motor axons and sensory axons are coated with a myelin sheath in the peripheral nerves. Now, this sheath is interrupted with the nodes of Ranvier. This helps in the faster conduction of your nerve impulse. Now, outside the Schwann cells, the axon is covered by a connective tissue which is called endoneurium. The axon is covered by a endoneurium. Now, a bunch of these axons are bundled into a group called the fascicles. Now, these are bound by the perineurium. An individual axon is covered by an endoneurium. A bunch of axons called fascicle is covered by the perineurium, and a group of these fascicles are covered by the epineurium, and this forms the nerve. Now, you can see in this diagram, the innermost component is a single axon that is covered by your endoneurium, that is the inside part. A group of axons form a fascicle that is covered by your perineurium, and a group of fascicles is covered by your epineurium around the entire nerve. Now, the sensory innervation of the limbs. There can be area of hyposthesia due to nerve injury, but it may be less than the area of skin supplied by that nerve because there is overlap of sensory nerve supply. So if you take a particular area, that might be supplied by more than one nerve. So even if a nerve is damaged, there might not be a complete hyposthesia in the entire area. Now, what is an autonomous zone? A relatively small area of complete anesthesia. It sometimes happens that that particular region alone is supplied by a single nerve, and that is called the autonomous zone. Now, these zones are found in all nerve injuries. Now, what are the anatomical features that are relevant to the nerve injury? Now, relation to the surface. Superficial nerves are most prone to injury by an external object because they are the superficial ones, like your median nerve in the wrist. Now, in relation to the bone, there can be an injury. So, this is commonly seen in the radial nerve injury in fracture of humeral shaft. Now, the relation to the fibrous septa, the nerve may get entrapped in the septa. Now, in relation to major vessels, if there is damage there, the nerve may get damaged along with them. Or if the course is in a confined space, example, the median nerve in the carpal tunnel syndrome. What are the mechanisms of injury that can happen to the nerve? The most common is an injury and dislocation. Next, there is cut and laceration, infection, compression, traction and friction, cooling or freezing injury, thermal injury, electrical injury, ischemic injury, toxic agents and radiation. it suffices to say that you need to remember that the most common is injury and dislocation, your cuts and lacerations, compression that can occur in compartmental syndrome, and the usual thermal, electrical, and ischemic injuries. Now, the classification of a nerve injury. The basic classification was provided early on by Seddon. He classified them into the three parts, that is neuropraxia, axonotmesis, and neurotmesis. On top of that, we have the transient ischemia. What is transient ischemia? It is due to the transient endoneurial anoxia, that is acute compression. It is a reversible condition. All of us must have experienced this. When you sleep on your arm for a long period of time, you may feel numbness and tingling. It happens within 15 minutes. After about 30 minutes of compression, there is loss of pain sensibility. After 45 minutes, there is development of muscle weakness. Now, the relief of compression, there is an intense paresthesia up to 5 minutes. Now, the feeling is restored within 30 seconds and full muscle power can be regained after 10 minutes. There is no need of any particular intervention at this stage. Now, the next is neuropraxia. This is also a reversible physiological nerve conduction block in which there is loss of some types of sensation and muscle power, which is followed by a spontaneous recovery after a few days or few weeks. Transient ischemia, there is just a few minutes, whereas in neuropraxia, it is few days or few weeks. Now, this is also caused due to mechanical pressure that causes segmental demyelination. It is usually seen in patients that are using a crutch or a tourniquet. Now, this can also occur in your Saturday night palsy. It is usually called in the Western literature as Saturday night palsy, wherein the person goes to a bar or a hotel, has a few drinks, and gets sloughed off on the chair with the arm compressed between the chair and the person's body. This is called neuropraxia. Now, what is your axonotmesis? This is due to the axonal interruption. There is loss of conduction, but the nerve is in continuity. There is only loss of the axon. That is, the neural tubes are intact. Now, Wallerian degeneration occurs distal to the lesion and a few millimeters retrograde. Now, axonal regeneration occurs within hours of the nerve damage at the rate of 1 to 2 mm per day. And if they are not re-innervated within 2 years, there is never a complete recovery. What is neurotmesis? This is a division of the entire nerve trunk. There is rapid Wallerian degeneration, destruction of endoneurial tubes over a variable segment, and scarring which prevents the regeneration. Surgical repair is completely required at this stage, and the function might be adequate, but it will never come back to the normal stage. Now, this is the grades of Seddon's nerve injury. The first picture shows you a normal nerve. The second one is your neuropraxia, where the nerve is intact, the axon is intact, but there is just a part of demyelination. There is a conduction block. Now, in axonotmesis, the axon is divided, but the nerve is intact. And in the fourth picture, you can see that the nerve itself is divided. Now, Sunderland has further classified it into 5 groups. Now, the first one is a focal conduction block. There is no Wallerian degeneration. Second one, axon is disrupted. Third one, along with the axon, endoneurion is also disrupted. Now, fourth one is axon, endoneurion, and your perineuron. The fifth grade is a complete disruption, that is axon, endo, peri, and epineurium. Now, what history is elicited from the patient? There is inability to move a part of limb. There might be weakness, numbness, and the cause might be obvious or may not be obvious. If the cause is obvious, the nerve affected and its level is easy to decide. When it is not obvious, history of injection in the nerve proximity, any medical causes like leprosy or diabetes should be elicited. Now, examination. The following observations should be made. First of all, the attitude and the deformity. Some peripheral nerve injuries present with a classic attitude of the limb and a deformity. Now, we commonly seen are wrist drop, foot drop, the winging of scapula, the claw hand deformity, the ape hand deformity, pointing index, and the policeman tip of deformity. And there is a wasting of muscles. It will become obvious after some time of the paralysis. This is not an immediate visible thing. Compare the opposite side always, because you might think the patient has a wasting of muscle because of a nerve injury, while the patient himself might be completely emaciated. Now, that is not a nerve injury, that is a systemic defect. There is slight wasting that sometimes goes unnoticed, and it can only be noticed if it is compared with the opposite side. Now, what happens to the skin? It becomes dry, glossy, and smooth. There is pallor or cyanosis. Now, trophic disturbances such as rigid and brittle nails, shiny atrophic skin are seen. The temperature. The usual scene is the paralyzed part has colder and drier temperature. What is the sensory examination? Now, different forms of sensation need to be elicited in a suspected case of nerve palsy, like your 2-point discrimination, vibration, pain, touch, temperature. Now, these are all carried over in the dorsal column. In the entire anterior column, you will have your motor examination that comes next. What is a sweat test? To detect a sympathetic function in the skin that is supplied by a nerve. The presence of sweating within an autonomous zone of an injured peripheral nerve reassures us that complete interruption has not occurred. Now, I have told you that an autonomous zone is a complete loss of sensation in an area of skin supplied by a particular nerve. Now, if sweating is present there, it reassures us that the nerve has not been completely lost. It translates into a better prognosis for the patient. Now, usual tests done are your Stark's test or Ninhydrin test, and you do the motor examination. Now, the regional survey of nerve injuries. Now, brachial plexus is most commonly seen in Erb's palsy and Klumpke's palsy. Now, what is your Erb's palsy? This can come as a 2 marks for you. The injury of C5, C6, and sometimes C7 nerves. It is common in overweight babies with shoulder dystocia at delivery. It can also occur in adults, but it is common in children during childbirth. The abductors and the external rotators of the shoulder and the supinators are paralyzed. Now, arm is held to the side, internally rotated and pronated. Now, this is also called your policeman's tip of hand deformity. What is Klumpke's palsy? It is injury of C8 and T1. Usually after breech delivery of small babies. The baby lies with the arm supinated and the elbow flexed. There is loss of intrinsic muscle power. Now, this is your Klumpke's palsy. Now, what does long thoracic nerve injury cause? Now, what are the roots involved? C5, C6 and C7 again. It supplies the serratus anterior muscle. The injury causes paralysis of the muscle, causing winging of the scapula. Now, you might be asked a question, describe briefly about winging of scapula. You need to remember that it is caused due to C5, C6, C7 root disturbance in the long thoracic nerve, which supplies the serratus anterior muscle. What does the patient complain of? Aching and weakness on lifting the arm. How do you test it? You ask the patient to push against the wall with the outstretched hands, like this. Now, on the affected side, there is winging of the scapula. Spinal accessory nerve. The root values are C2 to C6. C2, C3, 4, 5 and 6. It supplies the sternomastoid muscle and upper half of the trapezius. Now, what happens if there is injury? There is severe pain and stiffness of the shoulder with reduced ability to hitch or hunch the shoulder. There might be mild winging of scapula here also, but it disappears on flexion or forward thrusting of the shoulder. You can see on one side there is drooping. This is your spinal accessory nerve injury. The patient will be unable to hunch his shoulder on the affected side. Axillary nerve. The root values are C5 and C6 again. It supplies the deltoid and the teres minor muscles. The cutaneous branch supplies the skin over the lower half of the deltoid. Now, what is the landmark? It is 5 centimeters below the tip of acromion. It is supplied by the cutaneous branch of the axillary nerve. Now, what happens if there is injury? There is shoulder weakness and wasting of the deltoid muscles. Abduction can be initiated, but it cannot be maintained for a duration of time. Now, extension of the shoulder with the arm abducted at 90 degrees is impossible for this patient. This will give you diagnosis that the axillary nerve is damaged. There might be a small area of numbness over the deltoid because, as I have told you, the cutaneous branch supplies the lower part of the deltoid. Now, this is called your surgeon's patch sign. It might be asked for you in your orthopedics viva. The radial nerve, it is a continuation of the posterior cord of the brachial plexus. The root values are C5 to C8 and T1. Now, what are the motor branches of the radial nerve? Now it is divided into the anatomical areas. Before the radial groove, it gives rise to the branches to the long and medial heads of the triceps. After the radial groove, before crossing the elbow, it gives the branches to lateral head of tricep, anconeus, brachioradialis, and extensor carpi radialis longus. After crossing the elbow, it supplies extensor carpi radialis brevis and the supinator. After piercing the supinator, it gives your other extensor muscles of the forearm and hand branches. Now, what is the effect of a low lesion? Now, this might be due to a fracture or dislocation at the elbow or to a local wound. The patient complains of clumsiness, not being able to extend the metacarpophalangeal joints of the hand. There is weakness in the thumb on extension and retroposition. Wrist extension is preserved in the low lesion. In a high lesion, this might be due to fracture of the humerus or after prolonged tourniquet pressure. Wrist drop is seen in this case because of weakness of the radial extensors of the wrist. A high lesion of the radial nerve due to fracture of the humerus results in the wrist drop. There is inability to extend the metacarpophalangeal joints or to elevate the thumb. There is a sensory loss to a small patch on the dorsum around your anatomical snuff box. A very high lesion might be due to trauma or operations around the shoulder. And I already told you, it is also common in Saturday night palsy or crutch palsy. In addition to the high lesions, the triceps is paralyzed and the tricep reflex is absent. Now here you can see the radial nerve is vulnerable to injury below the spinal groove when there is a fracture in the distal third of the humeral shaft. What is a pin palsy? What is pin? Pin is your posterior interosseous nerve. It is a branch of the radial nerve. Now this is a purely motor innervation, that too to the extensor compartment. There is finger metacarpal extension weakness and your wrist extension weakness in pin palsy. There is inability to extend the wrist in neutral or ulnar deviation position, and the wrist will extend in your radial deviation because there is intact extensor carpi radialis longus that is supplied by the radial nerve, and there is absence in the present in the event of extensor carpi ulnaris lesion. The median nerve, it is formed by joining of branches from the lateral and medial cords of your brachial plexus. Now, what are the motor branches of the median nerve? In the arm, it gives no branches. In the forearm, it is again divided into proximal 1/3 and distal 1/3. In the proximal 1/3, it supplies all the flexors of the forearm except flexor carpi ulnaris and medial half of flexor digitorum profundus. In the distal 1/3, it gives no motor branches again, because you do not have any motor function. In the hand, there is thenar muscle innervation and branches to the first two lumbricals. A low lesion here causes generally due to cuts in front of the wrist or by carpal dislocations. There is inability to abduct the thumb. The sensation is lost over the radial 3.5 digits. Now, long-standing condition, there is atrophy of the thenar eminence. A high lesion is generally due to forearm fracture or elbow dislocation. The signs are, in addition to the low lesions that are seen, there is paralysis of the long flexors to the thumb, index and middle fingers. Long flexors to thumb, index and middle fingers are lost. Radial wrist flexors are lost and the forearm pronator muscles are lost. Typically, the hand is held with the ulnar fingers flexed and the index straight. This is called your pointing sign. In a high lesion of median nerve, with the hand, ulnar fingers flexed and the index straight is called your pointing sign. Now, the characteristic pinch defect is seen in the patients. What is your ape hand deformity? It is also seen in your median nerve injuries. There is inability to abduct the thumb. It is caused due to damage to the distal median nerve, also called median claw hand. And there is subsequent loss of opponent's pollicis muscle function. This muscle is required for your opposition of the thumb to all the other fingers. It can also occur with an injury of the median nerve, either at the elbow or wrist, impairing the thenar muscles and again the opponent's pollicis muscle. Coming to your ulnar nerve. This arises from the medial cord of the brachial plexus. The root value is C7, 8 and T1. What are the motor branches? In the arm, it gives no branches. In the forearm, again in the proximal 1/3, it supplies the flexor carpi ulnaris, medial half of flexor digitorum profundus. In the distal 1/3, there are no branches. Now in the hand, there is extensive innervation. Superficial branch supplies the hypothenar muscles, and the deep branch supplies adductor pollicis, all interosseous muscles, and the medial two lumbricals. Now once again, in the ulnar nerve, a low lesion occurs in the distal third of the forearm. There is sparing of the forearm muscles because it does not supply any muscles there, but muscles of the hand are affected. The patient complains of numbness of the ulnar 1.5 fingers. Claw hand deformity with hyperextension of metacarpophalangeal joints of the ring and the little finger is seen. Now these are the ulnar innervated fingers. There is hypothenar and interosseous wasting, and Froment's sign is positive. Now a high lesion. It is common in elbow fracture or dislocations. Motor and sensory loss are same as in low lesion. Hand is not markedly deformed because the ulnar half of flexor digitorum profundus is paralyzed and the fingers are therefore less clawed. This is called your high ulnar paradox. In ulnar nerve, if low lesion is there, there is claw hand, whereas if there is a high lesion, there is less clawing. Now this is your claw hand with an ulnar nerve lower part damaged. And you can see that the fingers supplied by the ulnar nerve, that is the ring and the little finger, are flexed, whereas the other 3 fingers are extended. Now claw hand will be asked as a 2 marks for you. This is what you should be writing there. It is 4th and 5th fingers extended at the metacarpophalangeal joint and flexed at the interphalangeal joint. Patient affected can make a fist, but on extension there is formation of the claw hand. It might be purely ulnar type or it can be both ulnar and median nerve type. Only ulnar type is your partial claw hand, whereas your mixed type is a complete claw hand. In complete claw hand, the other 3 fingers are also involved. Now your femoral nerve, it might be injured by a gunshot wound, by pressure or traction during surgery, or by bleeding in the thigh. Now features indicate paralysis of the quadriceps muscles and the patient is unable to extend the knee. There is numbness of the anterior thigh and medial aspect of the leg, anterior-medial numbness. Now the knee reflex is present, but it is depressed. There is severe neurological pain in femoral nerve injury. Now your sciatic nerve, this is the most commonly injured nerve in your traumatic hip dislocation and pelvic fractures, common in old age. Now the features include paralysis of the hamstrings and all the muscles below the knee. Because all the muscles below the knee are involved, there is no ankle jerk. There is loss of sensation below knee except on the medial side because it is supplied by the saphenous branch of the femoral nerve. The patient walks with a foot drop and a high stepping gait. Now picture A shows you the foot drop. There will be dragging of the fingers when walking. To compensate for the foot drop, the patients follow any of these 3 gaits. That is your waddling gait, swinging out gait, or your step edge gait. Now more will be told to you about these in your orthopedics. What are the treatments for nerve injuries? There is conservative management and operative management. Under conservative management, the paralyzed limb will be splinted, allowing for rest and regeneration of the damaged nerve. Mobility of the joint is to be preserved. The skin and nails, as I have told you, will go for brittling and dryness. Care has to be taken to prevent that. Active physiotherapy is to be done to prevent muscle wasting, and relief of pain is by your analgesics. Now, what is the operative management? There is neurolysis, that is external and internal, the nerve repair, nerve grafting, and a nerve transfer. Now, what is your neurolysis? Application of physical or a chemical agent to a nerve in order to cause a temporary degeneration of the targeted nerve fibers. We ourselves are going to cause a temporary degeneration of the nerve fibers in a targeted fashion. Now, this is done when the nerve is freed from the enveloping scar. Now, this is called external neurolysis. Operation where nerve is freed from the enveloping scar, it is called external neurolysis. Now, if the nerve sheath is dissected longitudinally to relieve the pressure from the fibrous tissue within the nerve, it is called your internal neurolysis. So basically, if you're preventing damage from the external scar, it is called external neurolysis. And if you dissect longitudinally to receive pressure from the within the nerve, it is called your internal neurolysis. Now, nerve repair, it might be performed within a few days of injury or later, but it is better if it is done within few days of injury. Now, what are the types? Primary repair, a delayed primary, and your secondary repair. Primary repair, it is indicated if there is a clean, sharp nerve injury. It is done within 6 to 8 hours of your injury. What is a delayed primary? It is done in the first week to 18 days after the injury if the wound is clean and there is no other major complicating injury. Now, what is a secondary repair? If the damage is crushing injury or avulsion injuries, there is delayed treatment done, usually after 3 to 6 weeks. What are the techniques of nerve repair? The first one is your nerve suturing. It is indicated when the nerve ends can be brought close to each other without considerable tension. What are the techniques? This is based upon the layers around the nerve. Epineural suturing, epiperineural suturing, perineural suturing, and your group fascicular repair. Now, as the names are self-explanatory. What is your nerve grafting? It is indicated when the gap is more than 10 centimeters or if end-to-end suturing is likely to result in tension at the suture line. The most commonly used nerve is your sural nerve because its function is minuscule. The other sources of nerves are your medial antebrachial cutaneous nerve, third web space branch of your median nerve, lateral antebrachial cutaneous nerve, palmar cutaneous and dorsal cutaneous branches of your ulnar nerves. Now, what are the methods of closing your nerve gap? The nerve on both sides of the lesion is mobilized. Relaxation is achieved by temporarily positioning the joint in a favorable position where the nerve can be without tension. Altering the course of the nerve, once again to relieve the tension. Stripping the branches from the parent nerve without tearing them to relieve the attachments. Now, sometimes you may have to sacrifice an unimportant branch if it is hampering the mobilization of the nerve. Now, these are the few signs of regeneration. How do you know that the nerve that you have repaired is regenerating? The first one is your Tinel sign. If you tap gently over the nerve along its course from distal to proximal, a pin and needle sensation is felt in the area of skin supplied by that nerve. We go from distal to proximal along the course of the nerve, and the patient will feel a pin and needle sensation in the area of skin supplied by the nerve. A distal progression of the level at which it occurs suggests your regeneration. It is usually at the rate of 1 mm per day. Now you can do the motor examination. The muscles supplied nearest to the site of injury develop first because the nerve grows over it. The muscles in the distal area, they begin to contract because they are re-innervated one after the another. Now, what is your electrodiagnostic test? It helps in predicting nerve recovery even before it is apparent clinically. The two tests done are electromyography and your nerve conduction studies. What is your electromyography? It is a graphic recording of the electrical activity of the muscle at rest and also during activity. A needle electrode is inserted into the muscle. It is connected to the oscilloscope screen and a loudspeaker. It is useful to determine whether or not the nerve injury is present, whether or not it is complete or incomplete nerve injury, whether any regeneration is occurring, and what is the level of nerve injury. In normal muscles, there is no electrical activity. Now, when the patient slowly contracts the muscle, there is recruitment of more than one motor unit, one after the another. Now, what is a motor unit is defined as the anterior horn cell in the spinal cord. The posterior ones are sensory and the anterior horns are motor. Now, when the motor axon is excited, it innervates the muscle. In strong contraction, the impulses of a number of motor units fire simultaneously, giving rise to your interference pattern. Now, in denervated muscles where there is nerve injury, what happens? The muscle itself has a spontaneous electrical activity. These potentials are normally suppressed by the nerve action potential. Now, this appears after 15 to 20 days after the denervation, and as it progresses, more and more denervation potentials appear. If this has not appeared by the end of second week, it is a good prognostic sign. What is your nerve conduction test? It is a measure of the velocity of conduction of impulse in a nerve. An electrode is placed over a point on the nerve trunk, and the response is picked up by an electrode at a distance or directly over the muscle. Now, between the 2 points, the velocity of conduction can be calculated. The normal nerve conduction velocity of a motor nerve is 70 meters per second. It helps to determine whether the nerve injury is present, whether it is complete or partial, and whether compressive lesions are present. Now, what are the prognostic factors in the result of a nerve repair? What are the factors that are outside our influence? Whether it is motor injury or sensory injury, the level of injury, the accompanying fracture, and the age of patient is outside our sphere of influence. Now, what can we influence? The delay between the injury and surgery and the proper surgical technique. That's it. Thank you. Now, what is a ulnar paradox? Now, PPT. Now, in your low lesions of the ulnar nerve, there is hyperextension of the metacarpophalangeal joints of the ring and little fingers, as you can see here. If there is a high lesion, the hand is not markedly deformed because ulnar half of your flexor digitorum profundus is paralyzed and the fingers are less clawed. Now, what is clawing? There is extension of your metacarpopharyngeal joints. Now, because in a high lesion, the flexor digitorum profundus is itself paralyzed, now the formation of a claw hand is restricted. The patient will have a claw hand, but it is less than what is present in your low lesions. Chat with us.